Welcome back. We're doing something a little different today.
A lot different, I'd say.
Yeah, you're right. Usually we take a broad topic and, peel back the layers for a more general audience.
Huh.
But today we're narrowing the aperture significantly.
We're going deep.
We're shifting gears into what I'm calling a clinical deep dive. This session has been specifically synthesized for the diploma level specialist.
Right.
So if you're tuning in, we're kind of assuming you have your clinical hat on. We're assuming a background in wound care, nursing, dermatology, something along those lines.
Because we're not going to spend time on the basics. This is not what is a rash.
No, absolutely not. We're going straight into the advanced management of Incontinence-Associated Dermatitis, IAD.
Exactly. Think of this as a masterclass briefing. We're going to be talking about the biochemistry of skin failure, the nuances of differential diagnosis that can trip up even experienced clinicians.
And we're going to critically evaluate the evidence behind the protocols we use every single day.
The goal here is really to complement the expert Q&A sessions you're already attending. We want to provide a robust clinical synthesis that you can take back to the bedside.
And before we get into the weeds, and we will, there's a mandatory and genuinely important acknowledgement we need to make.
It's crucial.
We have to extend a formal thank you to Dr. Abdul Karim. He provided the advanced source materials that really form the backbone of this whole discussion.
We're talking systematic reviews, neonatal incidence data, comparative studies on barrier films. It's high-quality stuff.
Without that data, this would just be opinion. It would be our experience. With it, we can actually look at clinical outcomes and evidence.
It's what allows us to move away from, anecdotal medicine, oh, I think this cream works best, and into genuine evidence-based practice. We can look at what the literature is actually telling us.
So let's set the stage. I'll be guiding us through this, sort of facilitating the discussion, but I really want you to lean into your role as the senior consultant wound care specialist.
Happy to.
I want that peer-to-peer, data-driven analysis. Let's bridge that gap between the research papers and the patient in the bed.
That's my favorite place to be. My focus is purely on the mechanisms, why the skin breaks down, and how we intervene based on physiology, not just on, tradition.
Perfect. So let's start with the scope of the problem. I think there's a tendency, even within healthcare, to view IAD as a minor issue.
Oh, absolutely.
It's just a diaper rash, right? But when you start to dig into the prevalence data, that whole narrative just falls apart.
It completely collapses. IAD is not a minor annoyance. It's a significant failure of skin integrity monitoring. And the numbers, they reflect a chaotic landscape.
How chaotic?
Well, we see prevalence data in adults ranging anywhere from 5.2% all the way up to 56.2%.
56%. That variance is massive.
It's huge. And in hospitalized neonates, which is a population we're going to discuss in a lot of detail later, we're looking at a cumulative incidence of over 32.1%.
So 1 in 3 sick babies is developing this kind of skin breakdown.
1 in 3. And that wide range you mentioned, the 5 to 56%, that's not a data error, it's a systemic error.
What do you mean by that? Why is it so hard to pin down a consistent number?
It speaks to the hidden nature of the condition. There's significant underreporting. First, you've got the stigma.
Of course.
Patients are embarrassed by incontinence. They try to hide the symptoms until the damage is severe, until it's painful.
But there's more to it from clinical side.
Oh, definitely. From a clinical administration standpoint, there's a massive lack of coding. Unlike pressure ulcers, which have very specific ICD codes and reporting mandates.
And financial penalties attached to them.
And huge financial penalties, IAD often just slips through the cracks. It gets lumped under general excoriation or moisture damage. If you don't code for it specifically, you can't track it accurately. It's invisible to the system.
And that lack of tracking, that invisibility, leads directly into our first major clinical hurdle, the diagnostic challenge.
Big one.
The literature provided points out that a huge percentage of IAD cases are misdiagnosed.
Misdiagnosed as pressure ulcers?
Yes.
And that is the fundamental error we need to correct today. If you take nothing else away from this deep dive, take this. You absolutely must distinguish the mechanism of injury.
Okay, so let's unpack this etiological lens you mentioned. How do we differentiate them at a biological, at a mechanical level?
You have to look at directionality. They are diametrically opposed forces.
Okay.
IAD is a top-down injury. Think of it as chemical warfare on the skin surface. You have urine, you have stool, you have radical pH changes attacking the stratum corneum from the outside in.
From the outside in. And pressure ulcers.
Pressure ulcers, or pressure injuries, as we should call them, are bottom-up injuries.
So from the inside out.
Exactly. They're caused by ischemia. Compression or shear force at the bone-muscle interface cuts off blood flow. The tissue dies from the inside, deep down near the bone, and eventually that damage reveals itself on the surface.
And this isn't just an academic semantic difference, is it? This fundamentally changes the treatment trajectory.
It changes everything. This is what we call the moisture versus pressure paradigm. If you misdiagnose a moisture lesion IAD as a pressure ulcer, what are you going to do?
You're going to focus on offloading, air mattress, turning schedule.
Right. You'll order the air fluidized mattress. You'll implement a 2-hour turning schedule. That's excellent for pressure, but it does absolutely nothing for the chemical irritant that is literally burning your patient's skin surface. The wound won't heal.
And the reverse is just as bad.
Just as bad. If you treat a true pressure ulcer with barrier creams thinking it's IAD, you're putting a bandage on a building that's collapsing from the inside. You're ignoring the ischemic necrosis happening underneath. You're treating the wrong pathology.
So, practically speaking, for the clinician who's listening to this, maybe doing a round right now, what are the visual cues? The sources mention blanching as a key discriminator.
Yes. Blanching is critical. IAD presents as diffuse erythema. It's blotchy, the edges are irregular, and critically, it is usually blanchable.
Meaning you press on it?
You press your thumb into the redness, it turns white for a second, and then the red color rushes back. That tells you the microcirculation is still intact, it's just inflamed, it's angry. It often has a glistening appearance. That's because of the serious exudate leaking from the dermis. It looks wet.
Okay, so compare that to a pressure injury.
A stage 1 pressure injury is defined by being non-blanchable. You press it, it stays red. That's the alarm bell. It indicates the damage to the vasculature has already occurred.
And the location and shape.
Also key, look at the margins. Pressure ulcers typically have very distinct margins. They're often circular or oval, located right over bony prominences. The sacrum, the caustics, the heels, the loading points. IAD is diffuse. It follows the path of the moisture. It's in the skin folds, the perineum, the buttocks, what we call the kissing surfaces, where skin touches skin.
The symptomology is distinct too, right? I mean, the patient's experience of it is different.
Very different. Pressure injuries are painful. A deep, aching, constant pain. IAD is characterized by burning, itching, and tingling. It feels like a chemical burn because, well, chemically speaking, that is exactly what it is.
So to standardize this, we have to move beyond just it looks red or it feels burny. The source material really highlights the necessity of objective measurement tools.
Yes. We have to get away from subjective guesstimates.
So let's talk about the instruments available to the specialist. The G-Lobiad tool seems to be the gold standard.
The G-Lobiad, that's the Ghent Global IAD Categorization Tool, is essential. It's been validated in something like 30 countries. It gives us a common language.
How does it work?
It moves us from a subjective, it looks bad, to a categorized system. It forces the clinician to inspect for specific markers. Is there skin loss? Yes or no? Is there a clinical infection present? It helps you classify the severity in a consistent way from nurse to nurse, shift to shift.
Okay, so that's for categorizing an existing problem. What about for risk assessment? We have the PAT.
The Perineal Assessment Tool, or PT. This is your preventative radar. It's brilliant. It assesses 4 key risk factors. The intensity of the irritant.
Like, is it just urine or is it liquid stool?
Exactly. Then the duration of exposure, the existing skin condition. Is it fragile? Is it dry? And other contributing factors like diarrhea or fever.
And it generates a score.
It generates a score from 4 to 12. The higher the score, the higher the risk. It allows you to intervene before the skin breaks. It's proactive, not reactive.
And finally, there's the IADS instrument.
Right. The IADS is for scoring severity. Once IAD has developed, it grades erythema, rash, and skin loss across 13 distinct body areas. It's on a scale of 0 to 52.
That sounds pretty complex.
It is, but for a specialist, being able to track a patient's score from, say, an 18 down to a 4 over the course of a week provides the concrete data you need to prove that your protocol is actually working. You can take that to management. You can justify your interventions.
That moves us perfectly into our next section, the pathophysiology. We know what it looks like. We know how to score it. Now let's talk about why it happens. This clean, protect, care protocol is the standard, but it's based on the underlying chemistry.
Specifically, the chemistry of breakdown.
I found this part of the reading fascinating, the ammonia shift. Can you walk us through the chemical reaction that's happening on the skin?
To understand the injury, you have to first understand the defense. Healthy skin has what we call an acid mantle.
Right, the pH.
Exactly. The pH of healthy skin is roughly 4.5 to 5.5. It's acidic. And this acidity is crucial. It acts as an antimicrobial shield, and it maintains the integrity of the lipid barrier, the mortar between the skin cells.
Okay, so we start with a strong acidic shield, then comes the incontinence.
Right. Urine contains a compound called urea. Now, the skin is colonized by bacteria, our normal skin flora. Some of these bacteria produce an enzyme called urease.
Urease, okay.
When urine hits the skin, that urease enzyme immediately gets to work. It breaks down the urea and converts it into ammonia.
And ammonia is highly alkaline.
Highly alkaline. It causes the skin pH to spike, sometimes to 8 or 9. When the pH shifts so dramatically from acidic to alkaline, two catastrophic things happen.
What's the first one?
First, the skin barrier becomes more permeable. The lipids that hold the skin cells together start to dissolve. The mortar crumbles. But the second thing, this is the most damaging part.
The what?
That new alkaline environment activates enzymes that are found in feces, specifically proteases and lipases.
Digestive enzymes.
Exactly. They are designed to break down the proteins and fats in the food you eat. But when they're activated on the skin surface by that high pH, they don't know the difference between a piece of steak and your stratum corneum.
Oh, wow.
They start digesting the skin itself.
That is a terrifying image. The patient's own biological waste is literally digesting their skin, all because of that pH shift.
That is the mechanism. It's enzymatic autodigestion. Then you add overhydration from the moisture, we call it maceration, which makes the skin weak and boggy. Then you add friction from the bed linen or the diaper, and the skin just shears off. That's the vicious cycle.
Which brings us to step 1 of the protocol, clean. And this is where we run into a major debate, or at least a necessary culture change in some places, the soap and water approach.
It's a tradition that absolutely needs to end. The evidence is crystal clear on this.
Why is it so bad?
Traditional soap is alkaline. If you are already fighting an alkaline shift caused by ammonia, scrubbing the skin with an alkaline soak is like pouring gasoline on a fire. It's counterproductive. It strips the natural lipids and completely destroys what's left of the acid mantle.
So you're making the skin even more vulnerable to those enzymes we just talked about.
Exactly. You're preparing the battlefield for the enemy.
So the systematic review source 1 recommends what instead?
Specialized, pH-balanced, no-rinse cleansers. These products are formulated to match the skin's natural acidity. They use gentle surfactants to lift dirt and bacteria without the need for harsh mechanical scrubbing.
And the no-rinse part is important.
Very, because you reduce the friction of toweling the patient dry. Every time you rub the skin, you risk causing more damage. The studies show, unequivocally, that these specialized cleansing regimens significantly outperform soap and water in preserving skin integrity.
Okay, so we've cleaned the skin without destroying its pH. Step 2 is protect. We need a barrier. But the sources draw a clear line between different types of barriers. We have zinc oxide, and we have these acrylate polymers.
This is a critical distinction for the specialist to understand. Zinc oxide is the classic, thick, white paste. It works as a physical shield, and it's been around forever.
But is it the best option?
The data from Glass et al. Suggests it's not the most effective option, especially for severe cases or for prevention. In their study, they found that patients treated with a liquid acrylic terpolymer, a product like 3M Cavalon is a common example, were 1.5 times more likely to show improvement than those using a zinc oxide-based cream.
1.5 times. That's significant. Why the difference? Is it about durability?
Durability is a huge factor. Mirasan and his colleagues did a study on barrier retention. They found that the acrylate films, which were coded as code A in that study, retained a significantly higher barrier percentage over time.
So it just sticks to the skin better.
It sticks better and it resists washout from incontinence. Zinc paste tends to just wipe off on the diaper or the bed linens. But there's another very practical factor to consider.
And that is?
Visibility. Zinc paste is opaque. It's a thick white coating. If you cover a wound or an area of redness in white paste, you can't see the skin.
You can't assess it.
You can't. To assess it, you have to physically wipe the paste off, which causes friction, causes pain, and causes more damage. Acrylate films are transparent. You apply them, they dry in seconds, and you can inspect the skin right through the barrier.
That seems like a massive advantage for daily nursing assessment. You don't have to disturb the wound to stage it or check for changes.
Exactly. It aligns with the first principle of medicine. Do no harm. Stop scrubbing the wound just to see it.
Okay, that makes a lot of sense. So step 3 is care or restoration. This is about moisturizers.
We often neglect this step. We clean and protect, but we forget to replace the lipids that have been stripped away. The stratum corneum needs moisture emollients to remain plastic and elastic.
And there's data to back that up.
There is. The data connects this directly to outcomes. We know that a program of twice-daily moisturizing can reduce skin tears by up to 50% in older adults. It's about maintaining the skin's own ability to stretch and move without tearing.
So we have the chemistry and we have the three-step protocol. Now let's talk about the future. Section 3 of our outline covers technological frontiers, and this is where we look at smart diaper sensors.
This is where clinical practice meets clever engineering, and we have a really compelling case study from Lee and Kim to illustrate it.
Tell us about the patient.
It was a 76-year-old woman with Alzheimer's disease and significant gait disturbance.
So the classic high-risk profile: sedentary, cognitively impaired, and nonverbal regarding her needs.
Exactly. Because she couldn't communicate her need to be changed, she was completely reliant on scheduled checks. This meant she would often sit in soiled diapers for hours until it was time for a nurse to do their rounds.
And the result was predictable.
Predictable and severe. She developed IAD. Her IAD score worsened from a 4, which is mild, to an 18 in just 1 week.
An 18 is severe damage. And this was while she was receiving standard treatment.
Yes. Despite standard treatment with desonide and antifungal creams, the standard care was failing because it wasn't addressing the root cause: prolonged exposure.
So they introduced the Monade system. Tell me about this technology.
It's a small sensor that attaches externally to the diaper. It uses Bluetooth low energy and capacitive sensing to detect moisture, and it's incredibly sensitive.
How sensitive?
It can detect as little as 0.1 milliliters of fluid, and the latency is less than 5 seconds.
So the moment the patient voids, a caregiver gets an alert on a smartphone.
Instantly.
Okay, so they switched her to this system. What happened to her skin?
The impact was nothing short of dramatic. It allowed for timely changes, real-time changes instead of scheduled ones. In just 2 weeks of using the sensor plus an antifungal, her IAD score dropped from 18 all the way down to 1.
From 18 to 1, that's near total resolution.
Near total resolution. And her PAT race risk score normalized.
And just to be absolutely clear, they didn't introduce some new miracle drug here.
No, that is the most important takeaway. The only change in the intervention was removing the etiological factor, the moisture, immediately. It proves that the single most effective treatment for IAD is keeping the skin dry.
It's incredible. We spend so much time and money debating which cream is best.
When a piece of technology that removes the guesswork for our nonverbal patients is arguably more effective than any pharmaceutical we could apply,
It effectively gives a voice to the patient who can't speak. It says, I need help now, not I need help in 2 hours when the next round starts.
precisely, it fundamentally shifts the standard of care from being reactive to being proactive or even real-time.
Speaking of pharmaceuticals, that's a good segue into Section 4, the pharmacological versus non-pharmacological balance. The systematic review you analyzed had some really specific findings here.
It did. It was a big one, synthesizing data from 644 participants. One of the interesting non-pharmacological findings was about absorbent pads. There was a study by Francis et al. That compared disposable versus reusable pads.
And my immediate assumption would be that disposables are better because they're super absorbent.
That's what you'd think. And they did find that disposable pads reduce the incidence of pressure injuries. But interestingly, they didn't significantly change the rates of IAD compared to the reusable ones.
That's surprising. Why?
It highlights a crucial point. Absorbency alone isn't the cure. You can have the most absorbent pad in the world, but if the chemical environment on the skin surface is alkaline and bacteria-laden because of that ammonia shift, the skin will still break down. The pad catches the bulk fluid, but it doesn't solve the pH problem right at the skin interface.
Fascinating. What about the hydrocolloid crusting method? I've seen this used in stoma care, but not as much for IAD.
Right, the crusting technique. You use a stoma powder, which is a hydrocolloid, and you seal it with a no-sting barrier film spray. You do it layer by layer, and it creates a sort of artificial scab over denuded skin.
And is it effective?
The Gunasagaran study showed that it is effective, but interestingly, so is standard care with zinc. The key takeaway for the specialist listening is that crusting is a valid tool in your toolbox, especially for those really difficult weeping lesions where a cream just won't adhere. The best approach might even be combining crusting with standard care for those tough cases.
Okay, now let's flip to the pharmacological side. We touched on this with the sensor case study, the use of antifungals.
This is a major area of misuse in clinical practice. The shotgun approach.
You see a red rash and
You reach for the combination cream with an antifungal just in case. The systematic review advises strongly against this. Antifungals should only be used when a fungal infection, usually candidiasis, is clinically present.
And how does a specialist confirm that clinically? What are they looking for?
You're looking for the classic satellite lesions, those little red pustules or papules at the edges of the main rash. If you don't see those, you probably don't need the antifungal. You're just applying a medication that isn't indicated, often in a base cream that isn't as protective as a dedicated barrier product.
What about steroids?
Proceed with extreme caution. The general consensus is against routine use of corticosteroids. Yes, they reduce inflammation, but their side effect profile is significant.
They thin the skin.
They cause skin atrophy. If you have skin that is already compromised and fragile from IAD, thinning it further just makes it more susceptible to tearing and secondary infection. They should be reserved only for severe non-infectious inflammation and used for very short durations under specialist guidance.
Okay. Let's shift our focus now to a very different and very vulnerable population. Section 5, risk factor analysis, but specifically in neonates.
This is a critical area. Neonatal skin is not just small adult skin. It's structurally different. It's thinner, it's more permeable, and its immune function is still immature.
And the numbers reflect that vulnerability.
They do. The data from Source 4 shows a cumulative incidence of 32.1% in hospitalized neonates. Again, that is a staggering number.
There was a paradox in this data that I need you to explain for us. The study found that neonates who were using skin barrier products actually had a higher risk of developing IAD. That sounds completely counterintuitive.
It does on the surface,
Yeah.
but this is what we call the reactive paradox. It's a classic case of correlation not equaling causation, at least not in the way you might first think.
So what's really happening?
In many neonatal units, barrier creams aren't used prophylactically on every single baby from day one. They are used after a nurse sees a red bottom starting to develop. So the data captures babies with barrier cream having more IAD, but that's because the cream was applied because they already had IAD or were on their way to getting it.
So it wasn't the cream causing the rash, it was the timing of the application reflecting the problem.
Exactly. The protocol in those cases was reactive, not proactive. The clear lesson here is that for high-risk neonates, the barrier needs to go on before any sign of breakdown happens. It needs to be part of the standard admission care bundle.
The neonatal data also showed that diet played a massive role in the risk profile.
Huge. A really significant role. We saw clear evidence that exclusive breastfeeding acts as a strong biological protectant against IAD.
Okay, and the risk increases with formula.
The risk increases with formula feeding, yes. But the highest risk group of all, with an odds ratio of 4.239, was the mixed feeding group.
That's fascinating. Why would mixed feeding be so much riskier than just formula alone?
It likely relates to the complexity and variability of the stool biochemistry. Breast milk produces stool that has a lower pH and a very specific enzymatic profile. Formula stool is typically more alkaline and has higher enzymatic activity.
So when you mix them.
When you mix them, or transition between them, you are constantly challenging the infant's developing gut flora. You're creating a stool composition that is particularly irritating to the skin. The study specifically pointed to fecal pH changes and instability as the likely driver.
And medications were also a factor.
A major independent risk factor. The use of oral medications had an odds ratio of 2.7, specifically antibiotics.
Because they disrupt the gut.
They decimate the natural gut flora. This often leads to diarrhea, loose stools, and it can allow opportunistic pathogens like Candida to overgrow in the gut, which eventually ends up in the diaper and on the skin.
It really emphasizes that IAD isn't just a dermatological issue. It's a systemic issue involving diet, gut health, and pharmacology.
Absolutely. You cannot treat the skin in isolation from the rest of the body. You have to think about what's going in to understand what's coming out.
We have covered a tremendous amount of ground today. I mean, from the diagnostic nuances to the chemistry of ammonia, the protocol debates, the technology, and these neonatal risks. Let's try to synthesize this for the specials listening. What are the big masterclass takeaways?
I think you can distill it down to 4 key pillars of practice.
Okay, pillar 1.
Differentiation. First and foremost, you must distinguish moisture, which is IAD, from pressure, which is a PU. Use the tools Julobiad for categorization, PAT for risk. If you treat IAD like a pressure ulcer, you will fail. The mechanisms are opposite, top-down versus bottom-up.
Pillar 2.
Chemistry. Alkalinity is the enemy. Your primary goal is to maintain or restore the skin's acid mantle. Ditch the alkaline soap and water. Use pH balance cleansers and durable transparent barriers like the acrylates. Stop scrubbing the skin.
Pillar 3.
Technology. We are on the cusp of a major shift from reactive care to real-time care. The smart sensor data proves that removing the irritant immediately is the most powerful intervention we have. It is often more powerful than any cream we can apply.
And the final pillar, number 4.
Systemic awareness, especially in the neonatal world, but it's applicable to all patients. Diet, antibiotics, and gut health are dermatological variables. You have to treat the whole patient, not just the skin they're in.
Excellent summary. Before we sign off, I want to leave our listeners with a final thought to mull over, something to take back to their teams. We talked about that Monite sensor system and how it reduced a severe IAD score from 18 down to 1 just by enabling real-time changes.
Right, and this brings me to a provocative thought, a question really, regarding our standard of care.
Go ahead.
We often accept high prevalence of IAD as some sort of unfortunate but unavoidable consequence of hospitalization or aging. But the data shows it is not inevitable. It's a failure of monitoring.
So the question that begs is,
The question is this. If technology like smart sensors now exists, and we have case studies showing it can virtually eliminate severe IAD in 2 weeks, does continuing with our traditional scheduled checks, where we might knowingly leave a patient sitting in ammonia and digestive enzymes for 2 or 3 hours because it's not time to change them, does that become an ethical breach?
wow,
Are we moving toward a world where not using real-time monitoring for high-risk, nonverbal patients could be considered a form of negligence?
that is a heavy question.
Yeah.
But it's one that every single clinical leader needs to be asking themselves. If the tool exists to prevent the injury, to stop the burn, why aren't we using it?
Exactly. I'd encourage everyone listening to take a fresh look at the IAD tool and, more importantly, audit your own unit's clean, protect, care protocols. Ask the hard question, are you truly being proactive, or are you just reacting to damage that's already been done?
A powerful thought to end on. Dr. Abdul Karim, thank you again for these incredible resources that made this possible. And to our listeners, thank you for joining us on this clinical deep dive. Keep asking those hard questions, and we'll see you next time.